Welcome to the LongevityMD podcast, where we discuss all aspects of health optimization. This is William Berger, MD, your host. Hello, I'm Dr. William Berger, owner and founder of Northeast Medical Practice. We are a concierge-style internal medicine, weight management, and health optimization clinic located in Great Neck, New York on Long Island. And on the LongevityMD podcast, we like to speak about all of those topics, and in particular, with reference to the weight management piece, we are fortunate to have Dr. Nina Crowley with us today. Dr. Crowley is a registered dietitian and also holds a PhD in health psychology. And she has nearly 2 decades of experience in the obesity and metabolic health space. She began her career as a dietitian in the bariatric surgery environment, and she currently serves as the Director of Clinical Thought Leadership and Partnership at SECA, who make the Bioimpedance device for body composition analysis that we're going to chat about today, which I really use extensively and love to have in my practice. She also hosts a podcast called In the Know with Nina, where she talks about the same sorts of topics, so obesity care, body composition, GLP-1s, and so forth with experts in the field. She was kind enough to interview me for the podcast just a few minutes ago, frankly. So welcome to our podcast on this side, Dr. Crowley.
Thank you. I'm so excited to be here and continue our conversation and talk about all the things. And as a fellow Long Islander, I'm happy to be back, although I'd like to come visit to really be there and be part of it again.
Sure. It is a nice place to live, but I know you're down in South Carolina, right?
Yeah, I've been here 20 years. I can't complain. It's really lovely.
Right. Also a lovely place to live. Okay, so we're going to talk about weight management and body composition analysis in particular. So maybe you can share with our viewers why the BMI itself is not the best measuring stick for somebody's health and their risk for various metabolic diseases, and also how they might be progressing toward better health over time.
Absolutely. So yeah, as you heard, I've been in the space for 20 years. So I've been talking about weight and BMI as a dietitian and as a, person in obesity care. We've long used BMI as a, criteria for bariatric surgery, but we've always sort of qualified that with, but, there's more to your health than weight and BMI. And for a long time, we've really said that, but not necessarily practiced that way. So it's been really refreshing for many, they've been doing body composition in clinics for years, but we're seeing a much bigger push, more globally, more as a standard of care towards using other things to assess health as it relates to body size and shape and composition, other than just the weight on the scale. And for most patients, it's a welcome shift in our practice, because that scale has done so many things over their lifetime to reinforce healthy or unhealthy behaviors, to, give them feedback about how they're doing, and so many, other more traumatic things that I've heard over the years. And so I think patients are especially excited that not only are their practitioners saying it's more than just about your weight, we're actually finally starting to show them that by using body composition scales or devices in our clinics, instead of just saying that, but then throwing them on the scale anyway and using BMI as it relates to like insurance criteria. So when you're looking at just a weight, you're looking at how much all of the things in your whole body weigh. And when we're able to actually say, well, why do we care about that number? It's usually the next conversation about cardiometabolic health and diabetes and heart disease and all of these other sort of conditions that we're saying excess weight or excess adiposity or excess body fat is related to those things long term. So when we actually are saying, okay, well, if it's related to that, why are we measuring just the scale? We don't really have a good answer to that, right? So when we're able to say, let's drill down on that. What does the excess adiposity mean? Well, we want to look at how much of all the molecules in your body are body fat or fat molecules, and how much is other stuff. And then we take that other stuff or fat-free mass and drill down further and say, what of that is lean tissue? And then what of that is skeletal muscle tissue, which is really what we're interested in learning more about. And so that's where we can start to see all of those components. And those are the parts that are actually more related to that health risk that we're talking about. And so when we're able to kind of partition the body into its smaller component parts, we're able to say, someone with one weight could be extremely healthy and someone at that same weight could be extremely unhealthy. And what that means is really going to be how we divide up those component parts.
Right, right. So often patients are frustrated because they don't see the number on the scale moving. However, if body composition were being done and tracking longitudinally, they'd see that perhaps they've lost fat mass and put on skeletal muscle mass, and their composition has improved greatly, although the number on the scale has remained exactly the same.
Right.
So maybe you could speak a bit to how the skeletal muscle mass really matters for longevity of the patient.
Sure. Yeah. And I was going to say, at no time is that more prevalent than sort of that middle age, right? Where people may say their weight's creeping up a little bit, but more often you're hearing people say, my weight's the same, but I feel different and I'm feeling more of that weight in my midsection, usually is what we hear. And so, even though the weight might be the same, we're seeing that shift, right? More central adiposity, more visceral fat, and less skeletal muscle. And so one of the big reasons that skeletal muscle is so important is that it helps us with mobility. And as we age each year and each decade, we are losing a little bit of that skeletal muscle if we're not doing some of the, intense things to protect it by, paying attention to our diet and nutrition and focusing on protein intake, as well as, doing some strength and resistance training and focusing on movement. If we're not doing that, we're going to see a slow decline. And so that's something that from a functional perspective and aging and frailty and falls, there's a lot of risk associated with that over time, that sarcopenia or sarcopenic obesity, even where maybe muscle mass is low and body fat is high. We're seeing that be associated with other health conditions and risk. But even further, it's related to a lot of the other metabolic processes in the body. And so some of the cellular level that's important, metabolic level with diabetes and some of the other conditions there with your liver, and all of these areas are impacted by having good skeletal muscle on our frame. And so it helps also with, just as the body burns calories, the more fat-free mass we have, the better we are at being more efficient calorie burning machines. And so something you can look at when people are losing weight is what's happening to their resting metabolic rate. And often when you're losing weight, that number's going down. But as someone's increasing their fat-free mass or their muscle mass, that's a really important way to keep that resting metabolic rate up. And the higher that is, the more calories you're going to be able to consume and stay at that same weight or lose if that's the goal. And so there's a big component of sort of the metabolically active tissue of that muscle tissue that really helps us as we're trying to sort of manage weight and stabilize and sort of recomposition through middle or older age as well.
Right. And of course, skeletal muscle is such a great sink for blood sugar that it can really help our patients who have glucose issues as well. And also just to be able to perform all those activities of daily living that we would like to be able to do into our older years. It's really critical to maintain that skeletal muscle mass. Some studies have stated that it's probably about 1% that you're going to lose every single decade, if not more. So you're working against the clock. And if you are also decreasing your adiposity, taking off fat mass, given that the body has less mass to move around, the skeletal muscle mass decreases on its own that way too, which is kind of the double-edged sword of weight loss in a way. And that, of course, is going to affect the resting metabolic rate, as you mentioned. If you have less skeletal muscle, you're going to have a lower resting metabolic rate. So
Yeah.
maybe you could tell people a little bit about what bioimpedance is able to do and how that differentiates it maybe from some of the other more consumer level devices that are out there and so forth.
Sure. Yes. Bioimpedance is one method of assessing body composition. There's a few different ways that we can look at body composition, and we won't go into all of those today. But one of the things I think is most important to say is when we're talking about assessment of your muscle mass, the best way to do that is by looking at like a whole body MRI, right? And that's not something that we have in a clinic setting or that we really would want to be looking at very regularly. I say that because SECA uses the whole body MRI as our validation metric. So it's an imaging technique for us to really look at what's happening with both skeletal muscle and visceral adipose tissue. And we do studies where we get that gold standard, they say, measure or imaging of the tissue. And at the same time, we do bioimpedance. And if we look at those two things together, we're seeing a 97 or a 98% agreement between the two. So we feel confident and comfortable enough with that, 97 or 98% agreement that we're able to then use just the bioimpedance in a clinic setting to assess that muscle mass or the visceral adipose tissue. And so what bioimpedance actually does is the device itself looks like a scale, kind of. You've got a foot plate, you've got a handrail. Some of them have a height rod so that you don't have to measure height. And you get on there.
You do have that one.
You do have that one? Yeah. So that's nice because that takes a big, component of measurement and error and everybody thinking they're taller than they are out of the equation. So you get on this scale. The difference compared to a normal scale in the look is just that you would get on it without socks or shoes, and that barefoot to the glass that you have, or there's electrodes underneath that foot plate. The electrodes are important because that's where you send a low dose electrical signal through the foot plate and out through the hands. So you're holding a handrail and you're putting your feet on those electrodes. And that electrical conductivity sounds a little scarier than it is. It's about the intensity of holding a battery, they say. So it's not shocking you, but that movement of that electrical conductivity through your body's tissues goes at different speeds depending on how much water there is in your body's tissues. So our muscle is about 75 or 80% water. So it goes through that rather quickly. And then our fat tissue is about 25% water, and it goes through that a little bit slower. And so the different speeds at which it goes through those body's tissues is calculated. And that's, the raw data values that we get are called resistance and reactance. You don't have to know those terms, but just know that those data values are entered into prediction equations that then estimate our fat mass, our fat-free mass, and then further down from fat mass or from fat-free mass, we go down to the skeletal muscle. So that's where you go back to that validation equation and making sure that those predictive equations are measuring what we want them to measure. And then the formulas, we look at them over time in different populations because different, age and gender and ethnicity have slight variability in their body composition. So those equations are important to use the data that we have from your demographic information. And it's a pretty quick assessment. You're on that device for less than a minute. It does the assessment. You put your socks and shoes back on, and then you go, kind of look at the cloud-based data platform together, and you're able to see several different parameters that look at, total body water, that look at your fat mass, your fat-free mass, and the location of your muscle in arms, legs, and torso, the location of your fat and your visceral fat, and a few other things. So the technology of bioimpedance has come a long way since we were in school learning about body composition. You used to have to lay flat for 10 minutes. They'd clip electrodes on your hands and feet and, wait for that body water to equalize out and then run an assessment. And so I find a lot of even fellow clinicians think that's what bioimpedance is, and that, it was a lot less accurate back then. It's come a long way. It's pretty quick and easy. It's a little bit harder to get that technology into a small, square, 12-inch square device at home. So those home scales are a little bit trickier, in part because they don't have the foot-to-hand technology in many of them. Some are just the foot. So it's running that from one foot to the other, and then formulas used to predict the upper body. And as people are heavier at higher levels of adipose or of weight, the formulas are a little less good at predicting that from half of a body. And so you do want to have something that has a hand component so that the bioelectric impedance is a whole body assessment. Some home devices have those as well, but positioning matters, and where your arms are each time you use it matter. Being able to spread your legs apart and not have it, think that you have one leg if you're standing in the bathroom naked and you're on your tiny little scale. So there's a lot of things that make the home assessment of body composition a little bit trickier. I find that, it's a good maybe secondary way to look at trending potentially. But as a, behavioral person and as a psychologist, I also find I don't really want people looking at their body composition every single day at home like we do with that scale. We want to give the interventions that you're working on with your doctor and your team time to work. And so rather than look at the noise in the daily measurements or the, kind of fluctuations in body water and weight, we want to give it at least a month or so to sort of say, hey, the thing I'm doing, the work I'm putting in the gym and in the, kitchen and, all of that, give that time to work so that if you see a change on your scale in a month, on your bioimpedance scale, you'd be able to say with a lot more confidence that that's related to the intervention, the work that you're doing in between visits, rather than just you woke up and this was a little bit higher. Because people can tend to sort of spiral out thinking wise when they're saying, this is higher. What did I have for dinner? I'll never have that again. There's a lot of things we do mentally when we think we're going to see a change and we don't, or it's the opposite of what we want that to be.
Right. And I do find that sometimes with the scale or with wearables, patients they can work against them. They can obsess a little bit about it, like the sleep rings and so forth are a good example of that. If somebody is worried about exactly what it's going to tell them in the morning, they often don't sleep as well as they would if they just set the ring aside. So sometimes having daily data at home can actually drive anxiety about one's health a little bit. So I understand what you're saying. I do try to get patients into my office on about a monthly basis to do their body composition analysis with the SECA so that it's much more standardized and so forth. How do you feel that when a patient has exercised or what their water intake has been and so forth influences the body composition analysis on the SECA? Do you recommend that people prep in a certain way, or they come in at a certain time of day, things like that?
Yeah, so I mean, we do say you want to do as much as you can within your control to standardize the conditions, right? So that if you're seeing a change, we can more confidently say it's because of the other stuff you're doing that you want to, measure. Is it the, nutrition or exercise that's changed the body composition? So to standardize, they do say, around the same time of day, but, again, in many practices that's hard to do. Like, is it 8 o'clock or is it 10 o'clock? And maybe more morning versus afternoon is something you could think of. You do want to go in a fasted state for a couple hours, voiding your bladder. You don't want to have exercise too heavy that day before. For both the day of, your temperature can impact the measurement a little bit. So if you're hot from exercising or doing cardio, we want to give time for that to dissipate and equalize out. If you're doing heavy lifting the day before, that can change some of the parameters because that changes sort of the drive of your water from inside your cell to outside your cell for that pump that you get. That can impact the measurements a little bit. So those are the couple things that I would focus on. And, then just at the clinic level, just making sure that you have that as part of your procedure. Where you're telling patients, to kind of come in that same way each time. All body composition assessment is going to have some error because we're not doing a direct assessment of their body composition because an autopsy is the only way to do that. So, we're relying on some sort of assumptions with the data. I would say, for the most part, if you're coming in pretty consistently, that we wouldn't have to worry too much about that. But if you do see a big jump that you can't explain from some other way, that would be worth drilling down and finding out if there were big changes or if, some medications can cause changes in fluid. And so, for the menstrual cycle, you want to maybe come around the same time of the month so that that's less of a factor. But even with all of those things, we're talking about a really small, maybe 1% to 2% change. So I wouldn't let that impact the flow of clinic or getting people in as much.
Right, right. And I was actually going to bring up the menstrual cycle issue because I have seen that affect the skeletal muscle mass theoretically by changing water distribution in the body
Yeah.
around that time.
And the other thing too, and part of my work is looking at when people have questions about their data, people will send in their results and say, why might this have changed? A lot of times, like just like with weight, you would see a change potentially, someone sending in something where there's a 8-pound difference in the weight from one time to the other, and then saying, why did these other things change, right? Like we do with bioimpedance want these numbers are going to add up to the total weight. So if your weight's off by 8 pounds, you're going to see that in one of the component areas, right? And you might see it in a little bit of both. So whether that's coming from, maybe the fat mass or the fat-free mass, and if the water is significantly up or down, that could also be related to that. So anywhere that you're seeing more water, it's going to be more like thinking back to the muscle, right? The muscle has more water than fat. So if something is showing higher water, you're going to say, okay, that's probably putting that into the muscle or the fat-free mass category a little bit more. And that'll be how it sort of represents.
Right. So and we've spoken to this already a little bit, that the one of the great benefits of having a bioimpedance device like the SECA is that it allows for longitudinal assessment. Maybe you can speak to how that's a benefit as compared to DEXA, because often patients are curious about DEXA scan. Is that what they should be doing? Maybe you can talk a little bit about how bioimpedance relates to the use of DEXA or compares to the use
Sure.
of DEXA.
Yeah, and I get this question all the time because I think a lot of my peers learned 20 years ago that DEXA was a gold standard for body composition. DEXA really is a gold standard for bone density. It's the only one of these technologies that can help with that. But it's giving you the component parts of your fat mass, your bone density, and then your lean soft tissue. So this is something that we see a lot of misrepresentation in language and terminology. People are calling it lean mass, they're calling it lean muscle mass, they're calling it, some version of that. But what they're referring to, if it's a DEXA or a DEXA validated bioimpedance device, some of our competitors use that, you're looking at that lean soft tissue. So if you subtract your body fat, you subtract your bone density, everything else is in that category. So that includes muscle, but it also includes your connective tissue, your skin, your, organs, a little bit of protein and things like that. That's not what we're really wanting to look at, right? What we're really wanting to see is the skeletal muscle. And so that's been one of the big things that I see a misunderstanding about, is people saying, well, DEXA is gold standard, but then they want to know about their muscle mass. And so that's where that disconnect happens. And so longitudinally, if you've gotten a DEXA done, I got one recently because they have some of these sites that pop up that do them, more for the consumer.
Yes.
I was shocked at a few of the components of that procedure, but also just in the interpretation and relaying of the results. It was this giant table with numbers, like I think my lean soft tissue numbers were something like 44,000 something grams. Like some of these numbers, I'm like, what does that mean? I don't have a calculator. I don't have an explanation
Sure.
of that. So some of those numbers are tough to understand. They were comparing to some really old NHANES data sets as the reference group. And they gave me a reference of, compared to a young normal, like what's a young normal? They said a 20-year-old. Okay, well, compared to a 20-year-old, my numbers were way off, right? So we also have to think about what the results are comparing you to, and the closer you can get to your age, gender, ethnicity, and weight class, the better you're going to be able to compare and say, like, here's where I stand compared to other people like me. And then longitudinally, I haven't seen where a repeat DEXA really shows you that data from a visual data perspective. You also have to go on the same device within the same office to really get the best data there. And that was a big component actually of one of the features of SECA that I worked on for the past year and a half, 2 years, is a feature called the treatment tracker. And that is a place where it's a new visual where you're able to put in what methods of change someone's working on: diet, exercise, medication, surgery. And then that's going to populate across the bottom. And then you're going to see what's happening to their weight, but also to their fat mass, fat-free mass, and muscle mass over the course of what's happening with their treatment. And being able to see that over time, to me, that's the visual that I wanted when I was in clinical practice with a bariatric program. Was here's their surgery date, what's happening with muscle mass, like when do I need to, or do I need to worry? Maybe not. But looking at just numbers over time wasn't enough for me to see the visual of like what's actually happening, and at what point is maybe this crossing over where fat mass is actually lower than muscle mass. That's a nice visual to be able to see. And, sort of what level of change. So that's been a nice feature to be able to look at changes in body composition. And also when you don't want to look at weight. I made weight the not default screen because I wanted people to focus first on their fat-free mass, their muscle mass, and not go straight to that, what's happening with weight. So by design, we're able to say, let's focus on what matters. And that's been a really nice feature to be able to have our metrics match what we're saying to the patients in practice.
Right. And I use those visuals with my patients as well. We don't really even focus on the body mass index very, very much. So let's leave that aside and let's look at the body composition, because that's really where we're trying to get the work done here.
Yeah.
If the BMI stays the same, but the composition improves, I'm not so concerned, particularly if we're getting the visceral adipose tissue down with its linkage to metabolic dysfunction and so forth.
Absolutely.
And we're bringing up the skeletal muscle mass. I think one of the other benefits of bioimpedance for longitudinal use as compared to DEXA, of course, is radiation exposure that you have with the DEXA. And also for kids, you don't want to be exposing them to that, but you might want to be tracking their body composition analysis. So another advantage of the bioimpedance device. Two, for, of course, clinicians to have a DEXA instrument in the office is also going to be cost prohibitive.
Oh, yeah. You could have six BIA devices.
Practices.
You could have one in each patient room, for that same price, actually.
Right.
Yeah.
Right.
And then for patients, when you're working with patients with higher levels of obesity, there's some space and size equipment level factors. Like,
of course,
they might only have a 350-pound weight limit and ours is 800. They might have to have their arms bound if they can't fit into the box for the scan. And I've had a couple patients tell me they started their weight health journey higher than 300 something pounds and they weren't able to get a baseline. So they've always wondered, what has medication or surgery done to my body composition? Because I had to lose 50 or 80 or 100 pounds before I could even get in the door to have that assessment done. So I think that's another factor. If you're treating patients of all sizes, you want to have a method that is pretty reliable at assessing their body composition before they start whatever that treatment's going to be.
Right, right. And I think it also really lets us see over time how the patient is really making progress. And I think that really can drive patients' motivation and keep them engaged and so forth. Maybe you can speak to that a little bit. I know I've seen it in my clinic that as they begin to take off adipose tissue, as the visceral adipose tissue improves, and of course the fact that the skeletal muscle mass, if you look at it in terms of percentiles, even if they're not putting on skeletal muscle mass, but they're decreasing their adiposity, of course that's going to rise into higher percentiles. Sometimes my patients are saying, well, I'm not putting on more muscle, I really want to put on more muscle. Well, bear in mind that it's becoming a larger percentage of your body mass as we take off the adipose tissue.
Yeah, that's a good way to put it. It's sort of the difference between the absolute and the relative numbers, and even some of the recent clinical trials that we see about the new medication options. You've got to really dig into that data to sometimes look at what's happening in their body composition studies, because if you're seeing a number decrease, like with your muscle, right? If you started at maybe 45 pounds and you see it now at 40, your mind's going to, oh my God, I lost 5 pounds of muscle. That's horrible. At the same time, your weight came down from, say, 300 to 200, you've lost 100 pounds and only 5 of that was from muscle. As a percentage, as you said, you're denominator, the bottom number, is going to be total weight. And so, you've got to sort of think about what's changing in the percentages and the relative change in those numbers in addition to the absolute, for sure. So circling back, you asked me about not just relative and absolute change. Completely blanking on the first part of your question.
So I was driving at how it can be used to sort of
Motivation.
drive motivation
Yes.
and engagement.
Yes, sorry, motivation. I think one of the most interesting parts about goal setting that we talk about is, when people first start talking about goal setting in the weight health or obesity care space, they often first come up to a number. I want to weigh this much weight. I want to lose this many pounds. And part of our work is getting them, pulled away from those type of patterns and thinking in numbers. But if you really challenge that, getting to a particular weight as a goal and then having to stay there year after year, that's not actually super motivating. It's not a number that you're seeing. Like, it's exciting when it's really far away, but when it's close and when you're there, maintenance of a sameness is kind of boring and unmotivating for making change. So I always think about this as almost like, what do athletes do? And in the fitness realm, these are people who their body weight may not change much over their lifetime, but they're constantly pursuing additional fitness goals and ways to get fitter and more athletic, or more, achieve new distance, or, other type of functional goals. So I think about that with body composition too, is that we can work to really change muscle mass and adiposity, and those numbers can be much better targets than that total weight and staying the same. So we can really, and they're small numbers, right? So even like a change in a pound of muscle, that's actually quite hard to put on a pound of actual muscle tissue. And so we're able to see change over time in that parameter. And that is way more motivating over time. And pairing that too, I would say, with some of the things that you're not seeing from the body composition equipment, but with the functional things in life of strength and function and gains, they say, gains in the gym or gains as they're able to pursue additional fitness goals. I think pairing those things together is a much more holistic way to look at health and longevity and all of these other things as someone's making those changes.
I agree, and I think also putting it into the context of your age as you go through this, in terms of what is your skeletal muscle mass, what percentage of your total body weight is it, of course, and then linking that to what you're doing in the gym and what activities you're still able to do, and also the aerobic side links to all of this. So, maintaining a high VO2 max for your age and so forth. Those kinds of goals are the things that I try to push toward with my patients. Once we've basically gotten the composition to the way that we would like, we've controlled the adiposity and so forth. As you say, what's next? What are we going to focus on? Because just keeping something balanced at the same point is not as much of an engaging factor as pushing to have more muscle and so forth. So I agree. I think it's a great way to keep patients engaged and motivated. So as we come to a close here, anything that you'd like to add with regard to body composition through bioimpedance?
Well, I love that you're doing this in your practice. I think you described it as being almost or more important than your stethoscope as a tool, which I think that's really exciting, because, for me, the change in standard of like our practice standards over time, that's really important. And I can just say, from working with patients over the years and with as a patient advocate, that being able to have a provider that has multiple layers of data and multiple things that they're checking and looking at really does give the patient a fuller picture of themselves as a whole person, and as a person that's able to function in multiple capacities. So I love that you're doing that in your practice. I think if you're listening and you're a patient who does not have a provider who's doing that, something that you can advocate for. And these days, patients do have a big voice in saying who they want to see and who they want to, interact with. And so there is some power in that. And if you're a provider listening, and you haven't yet gone into the realm of adding body composition to your practice. I think it's not only a patient motivator and a patient satisfier, but it adds value, even from a return on investment perspective. That's a whole nother story, and how we're able to monetize that. But really just the data that you can gather from that and linking that to your health and health change is really important. So I think it's a pretty big win from all directions.
I agree both as a clinician and for the patient. And I'll circle back to one thing you said. I of course have used the device myself in my office, and I don't perceive any electrical current, not even like putting your fingers on the 9-volt battery terminals or anything.
No, that's just to show how very low dose it is.
It's really imperceptible. Well, so I know that you also have a podcast. Maybe you'd like to talk about how our viewers out there might be able to learn more about you, about SECA, how they might get in touch, and so forth.
Sure, yeah. So we have a website. We've got all the social medias, SECA North America. But I have a podcast called In the Know with Nina. I have a nice glowing sign behind me for when we record. And I've been able to interview so many different healthcare providers and patients and, people in the field who are doing really exciting things, not just with body composition, but in clinical practice. I like to talk about sort of new cutting edge stuff and what's standard of with GLP-1 care and lifestyle medicine and longevity and all of that. I'm interviewing experts in the obesity space, functional medicine, lifestyle medicine, women's health, really practitioners all over who are doing body composition in their practice and being able to, share how it's working with their practice and with their patients. And I'm very active on LinkedIn, so you can search me, Nina Crowley. And then SECA has our social media channels, SECA North America. And we do for practitioners, we do a lot of education through webinars and through practice guides and print materials as well. So reach out, and I'm happy to connect with any patients or providers for any future questions on body composition.
Great. And I know that at a lot of the conferences that I go to, medical conferences, it's often a great way to see the device in person and to give it a try and so forth. The Obesity Medicine Association conferences, for example. I know that SECA is always out in force there.
We are, yeah. That's coming up soon. So I'm excited to connect with anybody who will be there.
Perfect. Well, Dr. Crowley, thanks so much for taking the time to be with us today. I'm sure this has been really informative for our viewers, and perhaps we'll have another conversation somewhere down the road.
Yeah, thank you so much for having me. I appreciate what you're doing.
Thanks so much.
Bye-bye.
To learn more about Northeast Medical Practice or concierge-style health optimization clinic, please call our office at 516-604-3418 or visit us online at northeastmedicalpractice.com. The information contained in this podcast and other media derived from it is for educational purposes only. It does not constitute the practice of medicine or any other healthcare services or the provision of medical advice or treatment. No doctor-patient relationship has been formed. Users of this information do so at their own risk. For any concerns or questions, users are directed to seek the advice of their medical professionals. The song Vital Signs was written by Neil Peart, Geddy Lee, and Alex Lifeson of Rush. Performed here by Dr. William Berger.